morning, everyone. Today's my topic is real-world outcomes of sutureless and glueless scleral fixated intraocular lens implantation. There's no financial interest. Visual rehabilitation in aphakia remains unique surgical challenge where implanting of secondary IOL is required. Situations where placement of IOL in the bag or ciliary sulcus is not possible. The AC IOL, iris fixated IOL, sutured scleral fixated and sutureless scleral fixated IOLs are placed. SFILs are placed at a point closest to the nodal point. Sutureless technique of the SFIL avoids suture-related complications. Aim of our study is to report the outcomes of sutureless intrascleral fixation of 3-piece intraocular lens in the ciliary sulcus in a large cohort of patients with aphakia of various etiology. The methodology includes, it's an interventional retrospective study. Institutional ethics committee approval was taken. Basic demographic data, pre and post-operative data, and early and late complications were noted. The SFIL surgery was performed as a primary surgery or a standalone secondary surgery or in combination with anterior vitrectomy, pars plana vitrectomy or silicone oil removal. And the surgeons were also categorized as junior surgeons with less than 2 years in practice and more than 2 years in practice as seniors, and the complication rate was also compared. The surgical procedure includes the making operatomy at 9 o'clock and 3 o'clock limbus with two partial thickness tunnels with 1.5 keratome, around 4 mm in length. And the sclerotomy is made at 1 to 1.5 mm from the limbus with a 24 gauge needle. A bent 26 gauge needle is introduced through the sclerotomy, and the haptic of the IOL is introduced into the lumen and exteriorized, both at the 3 o'clock and 9 o'clock limbus, and the exteriorized haptics were tucked into the scleral tunnels. And the conjunctiva is closed. For the statistical analysis, BCVA is converted to logMAR and paired t-test, chi-square test were used. All patients with a minimum follow of 3 months were included and less than 3 months were excluded from our study. Around 250 eyes of 246 patients were studied with a mean age of 56 years and the mean follow-up was about 6 months. The various indications for which SFIL was done was surgical aphakia, traumatic aphakia, IOL-related causes and the ectopia lentis. And as I mentioned, it was done as a combination with anterior vitrectomy or standalone surgery or along with the pars plana vitrectomy or silicone oil removal. The mean best corrected visual acuity of 20 by 110 pre-operatively improved significantly to 20 by 60 post-operatively. In the subgroup analysis also showed the significant post-operative mean BCVA improvement. The most common early complications were the vitreous hemorrhage and late complications were the cystoid macular edema. Other complications noted were hypotony, high IOP, retinal detachment, IOL tilt, scleral erosion, IOL subluxation or dislocation. When the junior surgeons and senior surgeons were compared, in each group there was a significant post-operative best-corrected visual acuity, and in between the groups there was no significant difference in relation to the visual acuity and also the complication rate. So technique of SFIL has been reported by many investigators for the management of aphakia. The above procedure avoids suture-related complications like suture knot erosion, IOL dislocation and IOL tilt due to the inaccurate suture placement. So our study showed a significant post-operative visual acuity improvement which was comparable to many other studies. There was 67% of eyes showed post-operative visual acuity improvement, 10% of the eyes showed same visual acuity and 21% of the eyes shows deteriorated vision. This could be due to the corneal scar post-penetrating trauma, pre-existing retinal diseases, post-operative complications like cystoid macular edema and retinal detachment. Other studies also showed similar kind of deterioration, but they have attributed the cause to the trauma for which SFIL was done. Vitreous hemorrhage could be due to sclerotomies through the vascular pars plica and the bleed through the superior sclerocorneal tunnel. Post-operative IOP rise was due to inflammation and steroid response. Hypotony must be due to the leakage through sclerotomy site. So other studies also showed similar findings where the hypotony and VH were high because of the 20 gauge needles used for sclerotomy, and there was persistent hypotony and persistent IOP rise, which was not present in our study. Late complications were cystoid macular edema and retinal detachment, which could be due to the complexity of the eyes, and incidence of CME is usually high in the sutured SFILs. IOL tilt, IOL subluxation which were noted, it can be avoided by the incarceration of a longer part of the IOL haptic into the scleral tunnels. Advantages for our study are large cohort of patients with adequate follow-up, significant improvement in the mean BCVA, comparable post-operative complications, no significant serious complications. As there was no significant difference between the complication rate performed by various surgeons, it may indicate the current technique is relatively easy and safe with a lower learning curve. Limitations of our study are retrospective study, lack of long-term follow-up, no control group, and presence of confounding factors. To conclude, this modified IOL technique of sutureless, glueless, scleral fixated IOL implantation is cost-effective, safe and easier technique of FAKR rehabilitation in the absence of posterior capsule, provided a good visual acuity outcomes in a large cohort of patients, and it's well tolerated. Thank you.
What were the total patients with complications out of, I mean, percentage-wise? I think complication, you are very honest in showing that there are so many complications, and visual results are also good. I mean, 67%
Mainly
of the...
it was the vitreous hemorrhage, sir, which was more common, and it was very transient. Around 2 weeks it has
I
come
think
down.
20% cases.
Yes, yes.
So what was the cause?
That
Vitreous...
was because of the sclerotomies which we make through the pars plicator region with a sharp needle. That could be the reason for the bleed.
The hemorrhage resolved of its own?
Resolved on its own, sir. None of them we have intervened, none of them were intervened for vitrectomy or anything was done for the vitreous hemorrhage.
Yeah. Have you compared these with the results of iris claw lens
No,
put posteriorly?
That was the limitation of our study because of there is no comparison or any...
Okay. I think that is a in thing these days. Yeah. Many people are doing it, and I mean, all this time taken is so less. Cost is like for your center, okay. And I think all these complications of vitreous hemorrhage, etc. The only thing is you should be knowing how to clip it.
And what is the reason of using 24 gauge for sclerotomy? You can directly enter with 26 gauge anyway.
Yes, sir, but nothing particular reason, but if the size of the sclerotomy is little bigger, it is easy to manipulate the needle with 26 gauge needle.
Maybe the haptic of this PMMA lens is bigger, thicker. Maybe with foldable IOL, that PMMA part is thinner. Maybe 26 gauge will do.
No, but...
but 26 gauge human, it is entering.
Yeah.
Okay.
Did you suture the scleroscopy in the end? Like they said it was bigger than what is required. So did you suture it in the end?
No, ma'am.